Okay, hi everyone. My name is Ariel Kramer. I am the founder of Clover Communications, and today I'm excited to introduce you to our finalists for the health equity category. We are the Digital Health Hub Foundation, a digital health accelerator at the Worldwide Center of Healthcare Innovation. Now it's in the sixth year. Our awards program is dedicated to identifying the most transformative, disruptive, and innovative companies shaping the future of healthcare. This year we had over 1,500 applicants and 300 were named quarterfinalists, and now we've narrowed it down to 150 exceptional finalists. Today we're proud to present our 4 best in class and 7 rising stars in the health equity category, leaders and companies who are really revolutionizing this industry. As a reminder, the session will be very fast paced as we have 11 companies to present, but this is only a small taste of what these companies are doing. So if the audience has any questions, please feel free to drop them in the Q&A and we'll get right to it. So now I'd like to introduce our executive, Matthew Holt. He will be running the session today, but first we have a word from Dia from Avia on our call to set the stage for what's happening in the space, and then I'll take it back over to Matthew. Thank you.
Great. Thank you so much for the intro. Hi, everyone. My name is Dia Buthandam from Avia Health Innovation. Really excited to be with you all today. For context, Avia Health is a services organization. We operate under a network membership model with over 50 health systems that we serve through digital health strategy consulting services. Really excited to be with you all today as we dive into health equity. A lot of the work that comes across my and my teammates' desk is around helping health systems understand how they can specifically advance health equity, both through specific targeted initiatives, but also how can they ensure that it's really embedded in all of the work that they do and all of their digital initiatives to really ensure that digital transformation that they do is in service of the goal of enhancing accessibility and equity in healthcare, rather than exacerbating existing divides. So with that, we can go to the next slide to just start setting the stage here. As health systems really work towards their overarching goals that might include things around quality, growth, community engagement, value, et cetera, a lack of focus and collaboration on the problems under the surface can really cost patients and health systems billions. These can include gaps due to provider shortages, implicit biases, access gaps due to financial constraints and lifestyle factors, and other general social determinants that greatly impact patient health outside of the hospital. So it's really clear that in the current healthcare ecosystem, we really need to shift our way of thinking and adapt our care models in a digitally enabled way to close the gaps that might be hindering health systems from reaching their quality goals. If you go to the next slide, we know that the opportunities to advance health equity in this space are really endless, but have done our best to really make sense of the crowded landscape by organizing them into 3 large categories. So the first being enhancing patient trust in their healthcare system, which really requires us to create safe spaces with diverse teams, community health workers, and culturally competent care to remove implicit biases. Empower patients with shared decision-making tools and education over their care plan. And finally, centering compassion by offering virtual peer support and other services to really let patients know that they're seen and supported in all aspects of their care. Next, we look at access, really ensuring that patients can get the high quality care that they deserve when they need it, which really requires us to move care into the home when possible, support the patient as they navigate through what can be a really confusing and overwhelming care journey, and connecting them to community resources that can greatly impact their broader health from a social determinants perspective. And then the third pillar that we really look to is enhancing the data piece. So really broadening the data that we're collecting on patients to analyze their patterns, develop social risk scores, understand their engagement habits, and really tailor and personalize the patient interactions across their care plans and outreach methods to maximize impact at the patient-specific level. So that's a high-level overview of the space as Avia sees it. This work is immensely important. It's at the core of what makes our jobs in healthcare so important and impactful. So I want to say congratulations to all the folks on the line that are committed to advancing health equity in their own ways. For every patient seeking care, and I look forward to the discussion. Before I close out here, I do want to add, as it relates to Avia and the work that we do, how we can help in addition to the consulting services that we provide. So if you go to the next slide, you'll see A few years ago, we launched the Avia Marketplace to help health system buyers across the country select digital health technology. So now over 70% of hospitals and health systems trust our marketplace for their tech select work. And this year, as a part of that, we launched buyer intelligence for solution companies like our finalists today to find active buyers on our platform. And as a token of appreciation to all the effort that companies have put into this competition, on the next slide, you'll see we provided free access to buyer intelligence. You should have reached an email or received an email from one of my teammates, Melissa, regarding the free access. Go ahead and reply to that email, or feel free to reach out to me or Melissa with any questions that you might have. Just wanted to mention that, but really appreciate the time, everyone. Looking forward to the discussion, and I'll pass it back to Matthew to take us through.
Thank you, dear. That's great. And dive in, everybody, and hopefully somebody will sell something to a hospital one day in digital health. Okay, I'm kidding. I know it's I know there is stuff going on, not often as quickly as we'd like to, as we might like. All right, I'm Matthew Holt. I'm one of the executive producers here at the Digital Health Hub, working with Mark Goldstein and Melissa and Ariel and the crew on this. I've been doing this, I think, since the first year, which is 6 or 7 years ago. It's fading into the depths of history by now. But this is perhaps the pretty eminent award show within health tech. And we like to feature two different types of organization within each category. One is we call the best in class or best in show, if you're a fan of that of that movie. And we have 4 of those with us today: Homeward, iPlato, which is part of Humor, Uno, and Sword. And then the other one is the Rising Star category, which has Clint, PearSuite, Amplify MD, Genie, Rhino Health, and Acclinate. I hope Amplify MD. Oh, sorry, I've said that twice. Meaning you weren't talked about earlier. So the way we're going to do this is we're actually going to break it into 2. So we're going to have a similar set of questions, but we're going to have discussions between kind of the 4 best in class, and then we're going to go and have I think it's 7 Rising Stars. So we're going to ask a very brief question of the 4 best in class, and then we'll get into some discussion. But for right now, if I could ask the Rising Stars to turn their cameras off and disappear, we'll invite them back in about 20 or so minutes. So that should leave us, hopefully, with Uno, iPlato, Homeward, and Sword Health. And look, it actually worked. Look, the miracles of technology. Okay, so we are going to just dive in. I am, as everybody knows, and who's been on my panel ever, that I'm pretty brutal on timing people. And we're going to start with a 90-second answer to the question. So the first question is, what does your company do? And more importantly, why does it impact and change and improve health equity? What are you doing in the health equity realm? And purely because she was late in coming, I'm going to bully her and put Dr. Jenny Schneider on first. So Jenny, tell us about Homeward.
Thank you, Matthew. So I'm going to start by healthcare delivery in rural America is not a little broken, it's massively broken. 60 million Americans live in rural communities, about 20% of our total population, and yet 80% of these rural communities are medically underserved. So 2/3 of primary care shortages happen in rural counties. People who live in a zip code designated as rural have a 23% higher mortality. So Homeward is catalyzing a sea change from health scarcity to abundance for rural communities and fulfilling the promise by connecting rural Americans with resources to be healthy. We address unique challenges through a hybrid model that combines digital tools with in-person support to build trust and scale. Through our tech stack, we maximize provider efficiency, reduce administrative burden, and enable timely and personalized care. Today, we work in partnership with insurance companies to provide care for Medicare Advantage beneficiaries. We take full financial accountability for entire rural communities across Michigan and Minnesota. Through our value-based care model, we align incentives with improved health outcomes. We connect the members with local resources and improve quality of life. We're working very closely and tightly in partnership with the existing healthcare providers and ecosystem in rural America.
I think you're cheating there, Jenny, because you're saying that everyone in rural America is by definition requiring health equity. That's probably right, and we'll probably get into some of these population things later. But that's amazing, and congrats on what you guys have achieved so far. And for those of you who don't know, Dr. Schneider was the chief. You were president by the end of Livongo, so you've been doing this for far too long.
For the bulk of Livongo, for the bulk of time there. Yeah.
All right, fantastic. All right, next up, Anna from UNO.
Thanks, Matthew, and good afternoon, everyone. So as Dia mentioned, access to care through finances is a big part of health equity. And I think most of us are familiar with the social determinants of health wheel that illustrate that about 50% of the factors impacting health outcomes are somewhat financially driven, access to finances, your environment, etc. We believe that cost is one of the biggest drivers, if not the biggest barrier to healthcare in the US, and we solve for that. 50% of the 70 million Medicare members have to make hard trade-offs between eating 2 meals a day, taking their meds, going to chemotherapy, paying their heating bill. And for younger Medicaid members, 100% of the 70 million individuals, cost of healthy food, transport to the doctor can be really challenging. So we solve for that by radically streamlining enrollment into state and federal income-based programs like Medicaid, food stamps, utility assistance, which on average would unlock about $4,500 of copay reduction and cash assistance every year, and really going a long way to closing that financial gap to accessing critical care. Amazing programs, but because they're so hard to get enrolled into because of complex eligibility rules, complex paperwork, about 50% of those eligible and not enrolled. So we basically develop technology to TurboTax through that end-to-end enrollment process, making it much easier to unlock that cash. And as a result, driving improved outcomes like reduced medical expenses, improved quality measures, and reducing churn.
Fantastic. So you're helping the Medicare Advantage members get the stuff they should be getting anyway, but aren't getting, basically.
Exactly.
Brilliant. Okay, fantastic. Okay, next up, Tobias from Plato.
Thank you, Matthew, and great to be here tonight. I'm Tobias, and I'm running a company called Huma Group, and we are a global health tech company. The programs we are running here are in UK based mostly. The NHS has been at the forefront of health equity, and partly because of this single payer system. We know very well that we know a lot about how different groups in society benefit from different services and uptake. And our challenge and what we have filed here for this particular award is around cervical screening. People in England are due for screening. That happens between the 25 years old and 64. And the program itself is credited to save about 5,000 lives a year. We've had challenges in London, for example. We have 65% uptake of this potentially life-saving service. And so our challenge throughout has been, how do we solve the health equity gap? How do we get underrepresented groups to engage with this program? It's behavioral, educational, socioeconomic factors, English not as first language, complicated. All of that plays into different groups in society. Effectively, some are diagnosed early and some are not, some live and some don't. And so it is the massive scale. Our intervention in East of England saved 29,000 screens in one single year, and their life saved as a result of that. And the beauty of it, of our intervention, was that actually the absence of variations between social groups. So you were able to...
I'll give you a chance to talk more about that later on, Tobias, but we're going to have to move on. Okay, thanks. But good to hear that. Good to hear the Brits are doing something. We have UK overrepresentation on this panel, as sometimes happens. Vijay, tell us about Sword Health.
Great to be here today. So 50% of spine surgeries in this country are unnecessary. And I mean in this country, in the United States. And that's similar for musculoskeletal care. What I say is the wealthy in the United States get care they don't need. The poor don't get care that they need. And few Americans are getting the right care. So the number one solution to improving this is really to get the right care, which in the vast majority of cases with musculoskeletal care is physical therapy. Why don't people get the right care? There are a lot of barriers to care, like time, transportation, cost, and these disproportionately impact people of color, rural Americans, underserved urban communities like the Bronx, where I worked for a number of years as a spine surgeon. AI care delivers physical therapy in a revolutionary way. AI, meaning artificial intelligence care, really revolutionizes the way we're able to expand access to the vast majority of Americans. What we find here is that when we actually expand care like this, we see the best outcomes with our members of color, with rural Americans, people from underserved urban communities, where we're able to really break down those barriers that disproportionately impact these populations. And I think also importantly is when we digitize a solution, we can't create new barriers, right? So we're very cognizant of that. We really try to minimize those barriers, for example, by supplying a free hotspot to anyone who doesn't have access to Wi-Fi. So this is where, when we create solutions that overcome existing barriers, we also have to be wary of new barriers and make sure that we're, really breaking those down as well. So that's what we do at Sword.
Fantastic. And by the way, I'm not only a panelist, I'm also a client. Although I understand that if I wasn't part of Blue Shield, I get the fancy thing on my phone that tracked my thing rather than having to wear the old sensors. But
I love it, yes, because computer vision has really revolutionized the way we do things today.
I think you need to talk to your friends at Blue Shield to bump up the level of coverage. It's the rumor I hear, but we'll discuss that separately. All right. That's great to hear what you guys are all doing, and obviously, it's a different flavor with each of you. I guess and then I'm going to be really brutal because this is now a 60-second answer I want from each one of you. But I want to know a real example from each of you of where what you did moved the needle with one of those with an underserved group. And they were at some point before and they were at some point after that made a difference because of what you guys and what your organization, your companies and products did. So let's start with Anna.
Absolutely. So we've been lucky to get to partner with some of our Medicare Advantage plan partners to demonstrate the pretty broad, deep impact of what happens when we put $4,500 of cash and copay reduction in a member's pocket. And the short is that with that cash, with that copay reduction, they go and take their meds and they go see their PCP, they go see their specialist. So what do we see in the data? We see an average reduction in medical cost of about $1,400. So that's typically from reduced inpatient admissions and more expensive cost of care. That gets coupled with an increase in prescription cost for the health plan, which is good because it means that people are taking the meds that they need to. That then results in a significant increase in really important quality measures like blood pressure, A1C measures, med adherence, all those good quality measures. So those get significantly improved. And then the one that we really care about for a number of reasons is churn. So when we deliver our comprehensive enrollment services, more members stick with their health plan for longer. And that's really important because whether you're a health plan or you're a value-based provider, all of the investment you make in a given individual patient member is only as valuable as that person stays with you. So the longer you stay with them, the greater the impact that you can have. Fantastic.
Yep. And there's a ton. And if you read the healthcare blog, which I also run, you'll see George Halverson writing about the impact of Medicare Advantage on the health of the underserved, a lot. And that's something which does not get, and there's a lot of debate about Medicare Advantage, and there will continue to be so, but that doesn't get surfaced enough, in my humble opinion. Tobias.
Yeah, I got carried away there. I don't want to repeat myself, but I think what we do see and what this is all about, at least for me, is this view of the pre-symptomatic diagnosis of disease. And we see, in terms of outcomes, we see people pretty much not weekly perhaps, but stories about people who are screened and a cancer caught early, and then leading to potentially a saved life. And of course, that is the miracle here we're trying to achieve, and where equity comes in, it's just people, different groups of society are underrepresented when it comes up with the services. So it is a direct challenge here, and actually coming back to the evidence we're looking at, it would be ideal if all groups of society, rich, poor, well-educated, not so well-educated, language barriers, cultural barriers, have all took up services, screening services in this nature. And that's exactly what we've achieved through our engagement method. So, it's
Okay, that's great to hear, and I think cervical cancer is obviously a thing. I think if I go back long enough, I think British screening rates were much worse than international comparisons some time ago. So I don't know. Hopefully, you're hoping to fix that. All right.
working.
Vijay, you started with a great. I loved your line, right? Which is that rich people get care they don't need, and poor people don't get the care they do need. And that's probably true globally, true in the US. And obviously, we don't have a single payer system here. We have lots of different things, different access to care. So tell us about a specific group that you sort of moved the needle with.
Great. So, I mean, what we see is, and we've done several health equity studies, the best outcomes when it comes to pain, functional outcomes, actually we see with our African American Hispanic patients. And when we actually look at engagement, we see double the engagement with our rural American population when we look at zip code compared to the average population. So again, when these barriers that disproportionately impact people of color, rural Americans, underserved urban communities, and we attack those, I think we're really able to make an outsized difference in terms of impact in these groups. I think there are three reasons. One, digitizing care breaks down the barriers in time, transportation, and cost that disproportionately impacts these groups. Two, we enable people to choose their own physical therapist. Why do I mention that? I think in healthcare, the person delivering care is as important as the care being delivered. That connection is so important when it comes to actually making a meaningful change in your health outcomes. And then I think also supplying the right technology, like the mobile hotspot that I mentioned earlier. So we kind of think through all of these things as ways we're breaking down barriers and how they translate into the outcomes that we're seeing.
Fantastic. I love that. You never offered me a mobile hotspot. I'm teasing. I'm probably not there.
It means I think that your Wi-Fi connectivity is quite good.
It seems to work. It's working better than Tobias's anyway today. So that's all good. All right. Fantastic. Jennifer, you've been at this for 4 years now? 3.5?
Two and a half.
Only 2.5. So you must have done something at that time. Tell us how you've moved the needle.
We have. So our Homeward Navigation is our approach focusing on managing the entire rural county through a combination of local providers, health system partnerships, technology, connection to local resources, and then our own clinical services. And when we enter a county, well over half of the people in our rural counties already have a primary care doctor, or they think they do. And still, there is a need to improve outcomes through the combination of the value-based care enablement services on behalf of health systems and bringing additional clinical capacity. When we launched and engaged members in Minnesota and Michigan, we've successfully been able to close 2.9 clinical care gaps per engaged members. 2.9 is a large number, and this is very tangible impact in these communities. And Medicare Advantage beneficiaries in rural communities have very high rates of chronic conditions relative to their urban counterparts. So lots of good work here to do.
Fantastic. No, I mean, lots of work and obviously lots of needed work. All right. Quickly, we don't have a lot of time left for this section. I want to raise the ugly point that you may have noticed there's an election coming up, and you may also have noticed that currently in the current administration, the health equity, diversity, inclusion, all that good stuff is actually, right there in CMS policy. It may not be, depending on who wins coming up in November in the US. So I don't know who wants to go with this, but what do you think that's going to mean for your work? Does anybody think that that's going to change anything? Are you going to have to double down on stuff? Are you going to have to change the way you behave? I want to get some things about where do we think health equity is going to be as a principle, in January, particularly if one side rather than the other wins. Perhaps I can go to you, Anna, first. This is, I want sound bites here, just, a few seconds.
Sure. Yeah, we've always taken the pretty cynical but realistic approach that to deliver a solution that scales and will continue to scale, that we have to deliver on top line revenue goals first. That plans our customers are not going to buy primarily on the outcomes, on the social determinants of health impact. And the reason why we, launched Uno is because there's a subset of the programs we support that drive immediate top line revenue value. So it sort of pays for the impact of all the health equity. In addition, as I mentioned earlier, one of the things we've really invested in is retention, which is an aspect of growth. So a secondary aspect of top line revenue. Our goal is then to continue.
I'll take that because we're all around some soundbite. Same question, Vijay. Do you think it's going to make a difference to you, or are you doing the same stuff? You're on mute.
I really think for us, this is about, whether or not, one candidate or other wins. I think we are going to be charting our course exactly the same way, which is, delivering the right care to every person.
Fantastic. Jenny?
Red and blue states all have rural parts to them. People who live in rural communities are white, black, brown, gay, straight, non-binary, different religions, and yet they have worse outcomes. We're going to stay the course.
Fantastic. And Tobias, hopefully the UK is not too affected by the US election, but you just had one yourself, so.
Exactly. Now, of course, everybody have their own personal opinion, and so do I. Preference and so on, but I just look at don't feel that there is a huge difference here. I think that preventative care, as far as we're concerned, is on the up, partly because it's been so underinvested in globally for so long or forever. So it can only get better.
Fantastic. All right. Well, some really fascinating information. Some 4 great companies doing really good work here. And I want to thank, this is for those judges who are watching and will be watching. This was our best in class group, which was iPlato from Humor, Sword, Uno Health, and Homeward. So please consider them. One of them will be getting the prize on Monday night at Health. And if I can say bye to our, you guys can switch your cameras off, say bye to our best in class, and say hi to our rising stars. You can switch your cameras back on. All right, you guys all heard that. You get the idea. You know that I'm being brutal on the time by looking at the webinar chat. So let's go right into this. That first question, if you remember, is what does your company do? And, who's using it? Who are the users? And how are you impacting health equity? And I'm going to start, because I bullied her yesterday about this, with Tatiana.
Thank you, Matthew. I knew you would somehow bully me again today. Well, CODA helps patients get the kind of care that they want by helping them plan that care in advance. Historically, this is done through an estate lawyer. Sometimes it can be done through a physician, but most patients don't have an estate to lawyer. And most physicians are generally too overwhelmed to play paralegal, which is why planning rates in this country are in the single digits, with minoritized and low socioeconomic status populations being at half of that. So CODA Health is a scalable B2B tech-enabled service for informed decision-making and advanced care planning. We have a patient-facing digital platform that's our one-stop shop for education, decision capture, documentation, and signature support for legal documents like advanced directives and do not resuscitate orders. And it's all integrated into the EMR so that doctors have real-time access. And for high-risk members, we pair them with our CODA advocates, so palliative care social workers, nurses that provide comprehensive support and family alignment as things start to decline. So one of our clients actually published a study in the American Board of Family Medicine Journal that shows that CODA not only tripled their plan completion rates, but we also achieved equal rates of engagement across race, gender, and socioeconomic status. So you don't have to take my word for it. You can go ahead and read it yourself. And at the end of the day, democratizing access to advanced care planning allows more folks to get the kind of care they actually want, including palliative and hospice, reduces family stress, and increases quality of life days outside of the hospital, which I think we should all be entitled to.
Fantastic, and bang on time as well. Please take that as your example, everyone else. All right, let's go to Amplify MD next, and Mina. You're on mute, Mina. Unmute. Come on, guys. Zoom's been around for 5 years.
I know. We should know this by now. Thanks, Matthew. Amplify MD is a virtual care efficiency solution that connects hospitals, clinics, and correctional facilities across the country to remote specialists so patients can get essential life-saving care whenever and wherever they need it. We have a 50-state footprint with over 15 different specialties covered, supporting over 200 facilities and facilitating over 100,000 specialty consults through our platform this year. And what is the problem we're solving? The fact that there's a huge shortage of specialty physicians in this country, with over 50% of our hospitals without access to specialists in at least 3 critical fields. We have vast specialist deserts throughout the country, especially in rural, low-income, and underserved areas, with patients in these communities often unable to afford traveling long distances for routine or emergency specialist care, exacerbating disparities and creating additional financial hardships for patients and their families. So how's Amplify MD solving that? We're enabling remote physicians to seamlessly cover multiple hospitals and clinics in a single shift, often in different states and health systems, using multiple EHR systems with a single simplified login and platform. This efficiency allows our specialists to work 2 times more efficiently so they can care for more patients in the same amount of time across a wider region so that we can deliver access to care whenever and wherever it's needed. Our approach is about strengthening local access, tackling the physician shortage through efficiency and ensuring continuity of care, and helping hospitals keep their doors open and deliver essential life-saving services wherever they are needed.
All right. So you're also emphasizing somewhat like home with the rural care aspect, but doing it from a telehealth, especially desert aspect. And that's a massive problem. By the way, not just in rural areas, but but elsewhere. All right. Next up is Clint with Rajesh.
Thanks, Matthew. So I'm Raj Dash. I'm a co-founder at Clint. I'm also a cardiologist at Stanford. And Clint is solving health disparities in clinical research and clinical care. Currently, clinical trials fail to recruit in over 86% of trials, and therefore that leads to delayed clinical development and life-saving therapies reaching the market and reaching those patients. And 55% of the time, patients are not receiving evidence-based care. This leads to worse outcomes, and in particular, disadvantaged and underrepresented groups are suffering the most from those outcomes being worse. Clint solves both of these problems. It has a clinical intelligence layer on top of electronic health record data that makes EHR data higher quality and more clinically accurate, and by codifying medical guidelines and inclusion and exclusion criteria for trials, shows health systems and clinical research teams every eligible patient within their entire health system who is eligible for that trial. You can sort that list by underrepresented groups, namely elderly patients, female patients, and underrepresented minorities and socioeconomically disadvantaged groups. By shining a light on those underrepresented groups, sites can oversample from those underrepresented groups and get more diverse patients into their trials. The FDA mandate to do this is best served by a Clint solution for life science companies and health systems to bring the best representative patients into their trials.
Thanks, Raj. And yeah, that's something that people don't think about a lot, but when you dive into it, as I've done in a couple of ways, the clinical trial thing, it's a big mess. Not to mention the fact that I think women weren't allowed in clinical trials till like 1980 or something. I mean, there's a lot of history as to why it's been so difficult. And if you're not a white male, you may not have been represented over the years properly. So fantastic. Very interesting. All right, brilliant. Up next is Colby from PearSuite.
Amazing. Hello, everyone. My name is Colby Takeda, the co-founder and CEO of PearSuite. At PearSuite, we're on a mission to empower community health workers. If you know anyone, they're extremely trusted and skilled and culture sensitive and passionate workforce, and they've been working with underserved communities for decades, primarily through the health education, navigation, resource thinking. However, up until recently, community health workers weren't properly compensated or integrated into the healthcare ecosystem, nor were they recognized for being a valuable part of the care team. Growing legislation and a growing focus on SDOH has changed this. However, CHWs are typically not on EHRs. They're on paper and spreadsheets and never contracted or build health plans, which is where PearSuite comes in. PearSuite is an all-in-one documentation building platform specifically for community health workers, built by community health workers. In less than 4 weeks, we can onboard community-based organizations and help them submit claims so they can work with health plans and support the work they're doing and help get paid for this work. We've also realized that we can't just be another tech company with great software. So we offer a comprehensive solution for training, clinical supervision, contracting assistance, support with compliance, audits, and claims. Working with community health workers takes patience, adaptability, and extra support to ensure adoption and engagement. And we've been able to successfully onboard over 150 organizations since launching last year with 99% retention. Health plans are also clamoring to work with CHWs, but they don't know how to, and there's inherent challenges. And through our platform, we'll be able to serve as a hub for these CHW organizations, enabling capacity for these health plans, which is why in the past 2 years, we've been able to onboard 20 health plans. Share more today. Thanks so much for having me.
Thanks, Kobe. And yeah, I think that's you're dead right that the idea of that, we need more than just pure clinical people to manage the health of populations it's very obvious, but somehow hasn't worked in the health system. So what you're doing is great. My dogs like it as well, as you can hear in the background. Anyway, all right, fantastic. Next up is Itai from Rhino Health.
Hi everyone, Itai Dan, co-founder and CEO of Rhino Health, also a physician and researcher in my background. Rhino Health provides the Rhino Federated Computing Platform to AI developers and data scientists in order to unlock health data for use in analytics and AI. In the healthcare world, over 97% of the data is siloed and unavailable for computation. Usually non-ivory tower centers are underrepresented in AI and analysis, and thus inequities are propagated into products. As a fact, over 90% of the data used for AI development in the US comes from 3 cities across the US. Rhino FCP uses edge compute and federated learning technologies as a way to allow seamless analysis and AI development on data that doesn't require data transfer or data sharing, thus alleviating privacy, regulatory, and cyber risks. Data never leaves the data custodian's firewall, and data sovereignty is maintained without having a limitation on what kind of analysis and model development you're able to do. We also use a Gen AI data harmonization copilot that makes health data machine readable and ready for analysis within a few days rather than months or even longer, taking messy real-world data and turning it into research-grade machine readable data. This allows data collaborations to receive data from new locations like the Middle East, Africa, EU, APAC, Latin America, etc., and takes data collaborations into the real world, where you can build global collaborations with diverse data, democratizes data, and brings more inclusivity in healthcare AI and analytics.
Fantastic. So an integration of data play, which is at the base of a lot of what we're talking about here from Rhino Health. Okay, next up, Kirsten from Genie.
Oh, thank you, Matthew, and thank you very much to Digital Health Hub. I just want to say, by the way, this is such cool company, so thank you that I get to be among all of you. This is quite a moment, and I'm super proud.
You will get a participation award for coming. Well done.
So while everyone here is empowering people, we're doing that too. Genie is removing one of the largest causes of inequity in the US healthcare system today, which is language barriers. One of them, but a big one. To be blunt, people are dying at disproportionate rates today simply because they don't speak English. And depending on which state in the US the patient's in, as many as 1 in 4 patients show up to medical appointments or procedures language discordant, meaning low or no English proficiency. And it prevents them from having conversations with their caregivers where they get to be diagnosed and treated effectively and accurately. In fact, they're 4 times more likely to be misdiagnosed because they speak a different language from their caregiver. And those misdiagnoses are 70% more likely to be fatal. So not a surprise that 55% of malpractice cases today, if loss of life wasn't enough, 55% of malpractice cases are attributed to miscommunication. Genie is a virtual mobile interpreting platform where we connect those caregivers to a live interpreter for access to language and cultural help just at the tap of a button 24/7, so any time of day. From any device that they have, the one in their office, the one in their pocket, the one in your pocket, smartphones or tablets, we connect them to live medical interpreters who are standing by to assist them in over 300 languages. In September, our average response time was 8 seconds. So on some level, think a very high quality medical grade, Uber for multilingual medical conversations. We're super proud to have 3,000 clients across the US in 150 countries, and we're helping those hospitals and clinics and doctors' offices, even companies like Raj's, to all see patients and include patients who are really in need at their most vulnerable moment but don't speak English. And our clients tell us that we help them stay compliant with the law, ACA Section 1557. We help them treat patients more quickly. We help them do it more accurately, and they've given us a 4.92 star rating. We did not get that to ourselves. We're
All
revolutionizing.
right, Kristen, I'm going to stop you there because you're bumping into the next time. But well done on the star rating. I think we get the role you're playing. And now we don't have a lot of time left. Only about 10 minutes left for the whole session. And I'm just going to go around real quick, and you can wave at me, raise your hand, or do if you want to get in this. But I'm going to ask a general question, which is I want all of you to tell me how you. Oh, sorry. I shouldn't. No, I'm not going to do that because I haven't got to Tiffany yet. Tiffany, I apologize. It's Tiffany from Acclimate next. Before we get into that session, I always screw this up somehow.
At Acclimate, we're on a mission to empower communities, especially communities of color, to take actions for better health. Like many founders, I co-founded this company with my co-founder with our personal stories. For me, I was given it for adoption because I'm biracial. My biological mom kept my 4 Caucasian siblings. And so I understood at a really young age what it meant to be marginalized for things that are beyond my control. My son was diagnosed with asthma. He was prescribed albuterol, which is unfortunately 47% less effective in African Americans and 67% less effective in Puerto Ricans. And so our business model is pretty darn simple. We have people here that live in the United States who are undereducated and are not engaged in taking actions for better health, which means that they're not included in clinical research. The FDA has, of course, come down and said that pharmaceutical companies need to invest differently in early community engagement. And so we specialize in that. We have a thriving community of over 150,000 community members from marginalized communities who are actively engaged in taking surveys and being involved so that we can change the way that pharmaceutical companies are doing business today. On the flip side, being a double-sided marketplace, we serve pharmaceutical companies through our Edict platform to make sure that they're able to have enhanced diversity in their clinical research. That was a condensed version just for you, Matthew.
Fantastic. I appreciate that, Tiffany. So let's go. I'm going to go back to you for the second question, which is I want to know, and it's great. We have two groups, you and Raj from Clint doing, fixing clinical research. We have a whole variety across the board with data and specialty care and interpreted clinical health workers, end of life and critical care planning. So a great diversity of people all doing stuff in health equity. It's fantastic. But Tiffany, tell me, have you really moved the needle with a particular group in your work?
Yeah, by doing the early community engagement, we understand that with Alzheimer's, a lot of African-American families take on their family members and keep them within their homes. And so we were able to work with a company called Lightship to help them diversify through a stage of, they believe it was a phase 3 study, the enrollment for diverse people in a particular study for Alzheimer's that happened in 2022. That's just one example. There's a case study on our website about the numbers. I know you said give you 30 seconds, so that's a spiel.
Oh, fantastic. Well, I was going to say you could have taken a few more, but I like the 30 seconds. You should win the prize just for being accurate and quick.
I tried.
You did very, very good. All right, brilliant. Next, Raj, you're in the same business, so tell me your answer to the same thing.
Yeah, so Clint is really able to help diversify clinical trial recruitment in a very focused way. I mentioned enriching your eligibility lists for those underrepresented groups. But just an example from the sponsor side, they're under a mandate, under the FDA mandate to do this. Otherwise, they may not approve their drugs or even publish their manuscripts of their trials. So we've had top 5 pharma companies come to us saying, can you help us find eligible patients across the country who are Black and Hispanic or Latinx or of a certain demographic? And we can do that almost instantly on our platform, align that and superimpose clinical sites and even identify PIs for them to go after to say, please onboard yourself as a site and recruit these patients for our trial. So we're really focused, and then we can transition immediately into giving those PIs identifiable lists of patients. And we are doing that actively with about 23 different pharma sponsors right now.
Fantastic. Itai, tell us how, this may be a bit weirder for you in the data world, but tell me how have you made a difference for a particular disadvantaged group?
Absolutely. So First of all, we've partnered with NCI in order to scale up pancreatic cancer detection AI to millions of patients across multiple localities in the US, including places where data is typically not provided through these kind of projects. We're helping diversify clinical trial recruitment by empowering a network of over 400 clinical sites worldwide that focuses on diverse locations. Latin America, Central America, Asia, and South United States, especially in areas that don't have the IT to do clinical trial recruitment themselves. We've unlocked an outcome research collaboration to identify gaps and create care improvements in patient journeys for breast cancer patients, which is, as you know, an underserved population. And we've in general enabled additional incremental to 60 global academic centers in developing and publishing research.
So you are literally all at global and doing this, all over the place with some great work there. Fantastic. Mina, tell us about how AmplifyMD has actually moved the needle with a particular group.
Yeah, as you can imagine, with both physicians and the platform driving efficiencies and access to care, we're making some significant improvements. In the outpatient setting, we're taking patients and hospitals that have wait times of 6 months to 9 months for seeing new patients in outpatient clinic, cutting that down to 48 hours, adding thousands of appointments available to these communities, and cutting patient leakage, which means a patient has to leave their local community to get care by 80%. In the inpatient setting, we're cutting transfers by 80 to 85%. We're increasing CMI, which means the level of complexity of the local patients. It's a real key measure for hospitals from in the mid 1.4 to 1.7 to the mid 2s to the mid 3s, which means there's more they're able to treat more complex patients locally, which is amazing for the patients who don't have to be transferred and can get care at home, but also for the hospitals who can keep their doors open without losing the revenue that these patients would otherwise bring in. We're helping patients in the ED with stroke times and response times of 30 to 38 seconds. We're helping psychiatry patients who come in off their meds and needing to be stabilized without having to be committed to an inpatient unit by responding to them in minutes, not hours. So there's no ED boarding. We're helping all these patients throughout the country, regardless of location, get the access to the care they need so they're able to go home healthy and better.
Fantastic. Great work there. Kirsten, tell us about somebody you moved the needle for with Jeannie.
Sure. I'll throw out a few kind of numbers here like everybody's doing. We've had the benefit of partnering with some of our wonderful hospitals. A study that we're doing with Mass General Brigham has actually showed our ability to increase the number of patient concordant meetings with their caregivers by 400%. And there was a 76% improvement on their outcomes as a result of having that language communication. We've doubled the number of patients that were able to access mental behavioral health services that they needed. We reduced no-show by 30% for patients with limited English proficiency. And we've actually shown an increase in satisfaction and HCAHPS scores. And while all that's very cool, I just want to say that the heartbeat of this are in like the small stories. Like we just had a woman who is in California. She spoke Quechua coming in from Guatemala. She was a migrant and she all of a sudden went into labor, premature, apparently did not know she was pregnant. But because of our Quechua interpreter being able to be accessed in less than 8 seconds, we were able to have conversations between her and the ambulance. And we were able to determine that she was pregnant, save her, the baby. And those are the stories that really kind of make what we do so special.
Fantastic. That is a great story, and just what a wonderful service. Brilliant. Colby.
Yeah, thanks so much. I think one of the biggest challenges with hard to reach communities is engagement and activation. Can we connect with the individuals that need help and can we get them to do the things that we know makes a difference, like annual wellness visits, screenings, vaccinations, and more? I like to share that community health workers are the answer. Community health workers don't have fancy degrees or titles. They utilize their lived experience, their local roots, their understanding of the community to address health and social challenges. Since launching last year, our software has been utilized in over 25 states. But I'll share one example of how our software empowered a small nonprofit supporting Black men in South Los Angeles. After screening 150 Black men, our platform helped to identify over 500 SDOH challenges and help community members address those challenges at 80% engagement rate. 80% is unheard of. And so I think it's just something we're really proud of, being able to support this population and support the group doing this work. Thanks so much.
That's brilliant. Fantastic. And, so much that we need to get to, right? In so many different areas of the SDOH and the Health Equity Challenge. And, that's great work. I'm very impressed with what you guys are doing. Brilliant. And I think the only person we haven't got to yet is Tatiana. Everyone else will squeal if they haven't been on. So Tatiana, tell us about how you move the needle for a particular group around end-of-life care planning.
Yeah, well, as I said in my introduction, equity of access is a core value proposition in our sales process. But at the end of the day, there's one story that really stands out and is close to my heart. My grandfather experienced homelessness several times in his life. And right now, CODA is being used in unhoused communities where the average life expectancy is 48 years old. These folks haven't seen their next of kin in over a decade. And at the end of the day, they still want the same access to care as everyone else in end of life and serious illness. So before CODA, not a single one of them had an advanced care plan. And in one encampment alone, over 3 months, 64 people created plans. Compared to the general population, they were 10 times less likely to choose a family member as their medical power of attorney. And over half said they'd prefer comfort care over aggressive medical intervention, which is not what we might normally think. So for a group that doesn't often get a say in their healthcare, I think this is a really powerful way to take back some control and allowed me to sort of affirm my own grandfather's personal experience way back when.
That's another wonderful story. I mean, that's a group who really are at the edge of that. Funnily enough, my business partner in Health 2.0, my co-founder Indu Subaya, is now running an unhoused group of providers for the unhoused in Los Angeles for a SCAN health plan. I don't know how she ended up doing that, but we blame Sachin Jain. Most things in healthcare are Sachin Jain's fault, if you know him. But anyway, fair enough. 1:55 West Coast time, which is the end of our session. So if you are either watching this live, we're going to pick this up as a video as a judge for the Rising Stars here. Again, you've heard 7 really phenomenal stories of companies, organizations who are really moving the needle on health equity. And you're going to see that the Rising Stars will be announced on the awards. The Rising Star announcement will be on the pavilion stage. So this is the pavilion stage. There's going to be a very large kind of, I think it's towards the back, Digital Health Hub Pavilion. It'll have a stage in it, and at 1 o'clock to 2:15 on Monday, that will be where these Rising Stars, the ones, I think 3 of you get a Rising Star award. I think might be 3, might be 2. I can't remember the exact number, but looking forward to seeing you there. So if you're a judge, please get those final judging in for this. The best in class, who you saw before, they'll be on the disco stage between 5 and 6. And then all of us will be at the Milos restaurant having a celebration, a party, and a drink to celebrate all the great work that's been done here. Because, when you work hard, you need to take a moment to have a drink and enjoy yourself occasionally. And with that, I want to thank everyone for watching, for listening. I want to thank Dia from Avia for giving us a good introduction. I want to thank all of our best in class and rising stars, and thank all of our judges and everyone else involved in the Digital Health Hub for this work in the health equity category. And looking forward to seeing you all at Health in, what is it? Just under 3 weeks? Someone can do the math for me, but soon. All right. Looking forward to seeing you then. This is Matthew Holt, one of the Digital Health Hub executive producers, signing off for now. Thanks and bye.